Great. Thank you very much, and thank you for inviting me to speak. Oh, okay, great. I guess I skipped my disclosure slide. Um, I I do an occasional proctoring for Intuitive, but only within our own system. And this project was funded by Northwestern Institute for Global Health. So surgical site infection is a significant issue around the world. In the United States alone, the estimates are it costs us anywhere between $3.5 to $10 billion a year. And we do know that implementation of enhanced recovery pathways that include infection control bundle can decrease rates of SSI for up to 40%. But globally, surgical site infections continue to be a significant issue, and there are multiple factors that affect it, from economics, it does cost money, to kind of lack of knowledge, oftentimes is just complacency, cultural factors, and everything mixed together makes it very difficult. There are a number of published projects and how things are done, but oftentimes they rely on a Western backers with a significant amount of money involved in trying to implement it. It makes it very difficult to continue and expand. Ukraine is a middle-income country in Eastern Europe. It's one of the biggest countries in Europe. But it's actually very low resource for the most part, and the rates of surgical site infection are estimated to be up to 25%, with everything that goes along with that, such as not closing wounds and significant burden on the system. So the aim for this project was to establish a pragmatic and flexible process that would allow us to implement this infection control and enhanced recovery measures, and since they go hand in hand, in various settings within the country. The primary outcome was actually to show the improvement in the validated measures for SSI and enhanced recovery, because we don't need to show that right antibiotics at the right time is going to work in Ukraine just as much as it works in Cleveland. And then the secondary outcomes were decreasing rates of infection, wound closure rates, and overall cost. So the project had 3 stages. The first, we collected the data, and we essentially did a surveys of everybody from surgeons and administration to the assistants in the OR, residents, and everybody else, and essentially to see if they think that certain measures are feasible to implement in this particular setting. And it was a Kyiv regional hospital that takes care of, it's about 900-bed hospital, takes care about population around Ukraine. We did the actual observation in the OR, trust by verify, and then we put this data together, and we went for a DMAC process, but I'll talk over a little in a little bit. And then finally, on the measures that we agreed are going to be feasible and doable, we did an education for all the parties involved, surgeons, anesthesia, nurses, and then patients. And then we did the surveys and observations again. And I think really the key was utilizing this DMAC process that we used in this country all the time for quality improvement when we bring all the parties together and and then decide what is that we can do, what are the efforts going to be. And when we did the initial part and we came up with this kind of efforts versus rewards, and what was interesting, you can see some things that they thought were feasible to do and would be doable. But what I want to point out, if you look on the left side, so for example, they thought that changing gloves was actually quite doable and quite feasible to do, but changing gowns, they thought the effort would be much higher, and it's because in this hospital they're using reusable gowns. That means if we keep on changing them more frequently, then by the end of the day they may run out and they have to stop doing surgery. So they thought it was not actually quite feasible to do. So once we did that, again, educational efforts, we talked to everybody, we presented at the different conferences, we printed out the things for patients so they would be kind of on board. And then finally, what did we see? So we used the surveys and adopted the surveys that we used in Northwestern actually for similar efforts. We started out with 27 practitioners on all different levels, went down to 12. It took us quite a while. The war did a bit of a number on this whole project. And then we did observations in the OR for 20 cases in the beginning and then 19 cases at the end. And we did do actually an instrument survey and adjustment that I'll come back to in a bit. And what we saw, so on the left, you see the survey. Essentially, is it feasible, is it doable for us at the regional hospital to be doing that? And they thought, for example, that carbohydrate loading beforehand and not shaving was actually quite doable. But if you look on the right side, again, trust by verify, they thought it was doable, but they were not actually doing a carbohydrate loading until we actually did the whole education. And then for shaving, we also saw a significant improvement in not shaving people a day or two before surgery. In the operating room, the survey, again, very similar. We saw improvements in sign-in, right antibiotics, redosing, right time. They thought that redraping, using the wound protectors was actually kind of feasible, but that improved significantly in a lot of these cases, reaching 100%. But again, if you actually look, that changing gowns, they thought before and after, that was not actually feasible for them to do. Now, when we went to observation, again, we saw significant improvement in all of these measures of antibiotics, using the wound protectors, right? And that was getting administration and everybody else on board and doing that. But what was very interesting, in the cases that they knew, but they don't have, they actually don't have that many cases booked, they started to change the gowns as well as they started to change the gloves and instruments and everything else. So it was actually kind of buy-in. And then after surgery, the same. In glucose control, dressing removals in the right time, we saw improvement in all of these measures. Now, the instruments is kind of an interesting part. We all I think, seen, the cases when you grab something and it's not great and you're trying to get it off the table and next cases show up on your table again. But down there, what we did, we actually contracted with an organization called Safe Surgery. It's a nonprofit that goes around the world. And what they do, they help refurbish, clean, and then teach people how to actually properly utilize and clean these instruments. And we brought them along, and they went through 63 kits, close to 7,000 instruments, out of which 783 were just done. They could not be used anymore. I can't even imagine what kind of fried meat has been sitting there for 10 years. However, from the ones that they were able to refurbish for us, we were actually able to use those instruments to now create the closing kits for them to use. Now, so overall, we did, even though it didn't reach statistical significance, the numbers are low, we did see the infection rates drop from 25 to 11%. Again, the numbers are very low. What was very, I think, good is that the skin closure rates actually increased close to 100%. And the whole project ended up costing about $15,000, but it included $10,000 that we paid for Safe Surgery to bring the equipment, teach people how to clean, and then leave it back in Ukraine. So, and then travel actually before it happened. So, small project, small size. It's actually required. This is an institution that I have a relationship with, which was, I think, big part of it. However, since that happened, another hospital adopted the same measures because some of the people went from one institution to another, and we're now going through this project at the National Cancer Institute, which is a kind of we're now switching from phase 1 to phase 2. And how to do that. So overall, I think this is a very pragmatic way to work with people to decrease the rates of infection and start implementing the processes that we do know work. And I think further studies need to be in looking at the instruments and what can actually be done to complement that. Thank you.